Good morning, everybody. One crossfire round has been over. Now again, second crossfire round is going to be started. So in this, we have a most eminent speakers, and both of them are vibrant speakers. So I think there will be a lot of discussion and counter argument amongst the two. In our crossfire round, we have the speaker, Dr. Rajendra Saoji, as well as Dr. Chandresekharam. So without wasting any time, I would like to start the proceeding. But to appraise the procedure, I have divided it into 5 minutes each for initial PPT presentation, followed by 2 minutes each for countering, and another 2 minutes each for recountering their arguments. And after that, we'll give the verdict. Anyway, thank you. Who will start? You will start. You will start, Dr. Saoji. Okay, I will request Dr. Saoji.
Hi, good morning, everyone. All the wise persons will rush where angel wouldn't fear to treat. And obviously, you can see the blue arrow which is going there. I'm going to speak for the motion for transhiatal approach for replacement of esophagus. Now, if you could see here, if you contemplate any esophageal replacement, it is always a major undertaking. So you can't have a rescue path first or you will manage it later. You have to adapt or familiarize yourself with at least one another technique so that you can tie over the situations very well. So rescue technique may not be always good. And of course, we all know native esophagus is good, that there should not be a situation for esophageal replacement. But when it happens, when the native esophagus is good, why not native root? So that is the point I would like to go ahead. Why posterior mediastinal root is better than retrosternal root. First of all, it's a very direct and straight course. What does it mean? There are no angulations and kinks. All the conduit, whether irrespective of their root, they empty by gravity. So therefore, better emptying is there when the root is straight and without any angulation. And there is ease of endoscopy and instrumentation should this patient require subsequently, immediately for the surgical procedure or maybe future in life. It is the shortest distance between neck and abdomen when it is through the natural bed. So it means that if you are using a conduit which will be certainly of shorter length and it is up to 4 to 6 centimeter. It is well contained between the two mediastinal pleura and it remains in the central line. So a misconception that it results into major compression of the airway and pulmonary is not really very well acceptable on a long-term basis. So there is less redundancy and very well placed stomach there. There are less anastomotic leaks in stricture because it has been shown in several studies. I have got ready Reckner there for references, where there is tension, interstitial tension of the oxygen is very good at the anastomotic site when you go by natural path. So the chances of leak and subsequent strictures are less. No wonder the quality of life with all these things are available on a long-term basis is definitely better with posterior mediastinal root. And of course, cosmesis. I wouldn't like my patients or anyone to see and pushing their bolus of food like this when there is angulation and they try to clear with different maneuvers and results. And of course, we have to know that almost 1/3 of this patient will have cardiac anomalies, where when you are in the posterior mediastinum for esophagus, the cardiac surgeons can go for their cardiovascular procedures where there is a completely virgin anterior mediastinum. For those who are not very familiar with the correct steps of posterior mediastinal approach are just made video. No. Video. Okay, he has taken up. Anyway, after initial cervical mobilization, there is esophageal stoma mobilization. After division of omohyoid and maybe some strap muscles, and creating a nice roomy space there for the anastomosis to come. Then you steadfastly remain on the center or the vertebral body and go down deep. Very easily you can glide up to the bifurcation of trachea without deviating here and there. Then you open the abdomen, take out the remnant esophagus of type A esophageal atresia, mark the fundus, close the stoma, close the OG junction, pyloroplasty, and here is the important step, how much of the width you will require for the tunnel. And that is how you first create a tunnel from below, join it with the upper one, and then widen it with your 1, 2, 3 fingers as much necessary. All this will happen within, say, 10 to 15 minutes of time, particularly when there is no fibrosis at all. So this is what it is happening, and at the end of it, the stomach should glide very easily and come into the neck, and it should have same color as it was seen in the abdomen, and if it is seen there in the neck, you are through. So it doesn't really carry a really very much blamed sort of a challenging technique or a very difficult technique. So with this is a very central, nicely placed stomach to show you, and the lateral view of the same. So with this very strong points in favor of posterior mediastinal approach, I would like to strongly recommend posterior mediastinum as a route of waiver.
Thank you, Dr. Saoji. Now, Dr. Chandresekharam, you have to counter the statement. Okay.
Very good morning, my dear teachers and friends. विकेश अग्रवाल मुझे हनुमान के साथ कुश्ती लड़ा दिया. I mean, he has chosen me to argue with the master of gastric pull-up and esophageal replacement surgery himself, my dear friend Saoji. But I have had a modest experience with esophageal replacement surgery myself. So, and I have been doing all these procedures by retrosternal route. So I think I'll present some arguments in favor of a retrosternal route. So, what are the ideal prerequisites for an ideal esophageal replacement or esophageal substitution? I think I have marked the most important things in red there, and these are the three factors where a retrosternal route would actually score over a posterior mediastinal or a transhiatal route. It's much simpler to perform technically, it's reproducible even by youngsters, and it's even adaptable for small children. And it does not cause mediastinal compression or respiratory symptoms. Basically, another addition to this is cardiac arrhythmia, sinus tachycardia, and bradycardia have been known to occur when the stomach is pulled through the posterior mediastinal route. That is not a problem with retrosternal route. And then I'll show you evidence that gastroesophageal reflux, in fact, biliary gastric reflux is much lesser after retrosternal placement of the stomach than in the posterior mediastinum. The problem is majority of the papers on retrosternal gastric pull-ups are in adults, and there are very few pediatric papers. So I have to take my data from adult papers. So it's technically easy and simple. If you see the same diagram which Dr. Saoji showed, you can see there the green area, the light green area behind the sternum, there is absolutely nothing there. It takes hardly 5 minutes to make the tunnel, a retrosternal tunnel, for even a not so expert esophageal replacement surgeon like me. And then technically very easy to develop and enlarge. You don't have any problem with compression of any mediastinal structures. You don't have a problem with the irritating the nerves and then causing tachycardia or bradycardia. And so that makes it an ideal route. Now, there is some, as we discussed, some additional dangers with trying to blindly dissect in the posterior mediastinum transhiatal route. Like placing the bulky stomach in the mediastinum may cause respiratory distress, and decreased venous return has been reported in children. And the need of beta blockers, because there can be inappropriate sinus tachycardia in these children. So the need of use of beta blockers has been recommended by many authors when the posterior mediastinal dissection is done for placing the stomach. Now, what are the advantages of retrosternal route? Now, unlike common knowledge that we have, that what Dr. Saoji has said, the retrosternal route is actually supposed to be the shortest route to the neck and not through the posterior mediastinum, because the reference points initially which were used to measure the length were actually wrong. So the new reference points, which are fixed points, this has been published in the Journal of Surgical Research, that Young et al. have actually measured the distance, and they found that retrosternal route is the shortest route to the neck and not the posterior mediastinal route. And as I said, it's been documented in adults at least that retrosternal route of the stomach placement causes much less duodenogastric reflux than the posterior mediastinal route. And the authors have actually recommended that retrosternal route may be a better alternative, especially in patients with a long life expectancy, which all of our patients are. So this is another point, of course, from adults. And it's a virgin route, as we discussed, especially when there is a leak after esophageal atresia repair or after caustic strictures of the esophagus. The posterior mediastinum, there is a lot of adhesion. So the retrosternal route is a virgin route. And I don't know, my friend Saoji said anastomotic strictures were greater after retrosternal, but the evidence actually suggests that they were very similar or comparable to the posterior mediastinal route. And majority of cases, because there is no compression on the major mediastinal structures, there is no need for post-operative ventilation with this approach. Special precaution, you have to enlarge the thoracic inlet well so that the stomach reaches there easily. These are my pictures. I mean, again, you can see that the stomach, which has been pulled up into the neck, has a very similar color as the esophageal stump, and the anastomosis is very clean and neat in these patients with retrosternal route. I do about 1 case of esophageal replacement with gastric pull-up per year. It's not a great number, but my results have been pretty decent with this. So my motto is keep it simple. Thank you.
Thank you both the speaker for their argument regarding the favor of each technique. Now I would request Saoji to counter at the statement of.
My worthy opponent, VVS, was too much overwhelmed when I was presenting, and probably he was just thinking and finding out a very, as I said very clearly that time, no esophageal replacement is a simple undertaking. So you cannot have simple things to go about it. Whether you do by subcutaneous route, you do by substernal route, you do by posterior mediastinal route, whichever route. So there is no question about it. You have to be good what patient requires and what is the nature has provided. Second point he has put up was ideal esophageal replacement. There is no ideal replacement available with whatever which is available, and current even research also doesn't guarantee that. Third important point, what is more important, I would like to suggest my worthy opponent, is that entire foregut works in concert. So if you try to repair only esophagus, you have got airway there, you have got stomach there, so you cannot have that balance. So you cannot talk of idealism or a simplicity here. You have to take important decision, and you have to be prepared for that. He said duodenogastric reflux is less as compared to posterior mediastinum. Well, it is there. If it is less, it is there still. So you can't rule out there is no reflux or very significant advantage to it. Third thing, he was a very, I think you made a monumental blunder in talking that you can take out scarred esophagus. So either you are deciding to keep that scarred esophagus there, for whatever reason it damaged esophagus you need to remove, and then you will go for the retrosternal route. So either you are leaving behind a danger there, or when you are already taking out, you have gone to the mediastinum either by thoracoscopy, thoracotomy, the nice channel is created. What hinders you from going for posterior mediastinum? That is my question to you. So that is how, so you can't have that escape from that. Secondly, you have to look at not only from initial few days or immediate early period, because whichever route you take, whichever type of procedure you do, whichever type of setting you are in, the stormy period is always there. It depends upon the type of case you are dealing with. So if you can tie over first few months, you have got a very nice, a long, really very good outcome. I know my worthy opponent is very savvy of evidence base. Perhaps he has got evidence bias also. I can give you innumerable references where these are the references. The crowding shear you can make out. If you want, I can give you detail. Along with my personal experience, 134 cases out of 136, there was sort of no issue in creating a tunnel. So that itself is a very overwhelming point in favor of it. Another very outstanding study, meta-analysis, which is published. Basically, there is no significant or very major literature as far as pediatric is concerned, but this meta-analysis is a very nice one, published in the Annals of Gastrointestinal Surgery by the Japanese team. And see the effects. The anastomotic leakage, pulmonary complication, mortality leave apart because that pathology is different. They have done for cancer surgery. Our surgery is benign surgery, and we have to look for next 70 to 80 years. So that is a very important point. Now coming to the fallacies of length, you have given only one example. If you want, you have here some 7, 8 studies available there. There is the fallacy of this is that whether they are cadaveric or a real living study. Second thing, what is the reference point? The upper reference point is quite fixed in every study, that is the lower border of the cricoid. But what about the lower? Someone has taken celiac axis, someone has taken gastroduodenal artery, someone has taken pyloric ring. So all these things will differ, and if you look into this, I don't have here pointer. If you look into that, half of them are also showing, and the significant -5 point thing is the one which is always quoted everywhere. The shortest route is posterior mediastinal route. So I am telling my friend, please be patient. You take time, but do a great job so that patient should not have to worry about. But VVS is in very much haste. He want to take a rescue and want to go by very fast way. He says, I can fly off. But the bliss of swallowing ultimately is by transhiatal route. So therefore, I strongly recommend that.
Thank you again. Now, Dr. VVS to counter.
In fact, when Vakesh, he allotted me to the previous crossfire initially, but then he said, VVS, there's nobody to speak on retrosternal, so why don't you speak on it? I know you do that operation. So that's when I agreed that I should speak on retrosternals. I have fired all my arrows or shots in the first slides, so I don't have any more slides left. But let me tell you this. There is very little literature available on retrosternal route of gastric pull-up, at least in children. In fact, majority of the literature comparing these two is also in adults. The problem is the pathology in adults is totally different. So it's usually for malignancy, and they are not expected to live for very long after that. But in children, I think we are looking at a very long life. And so I think at least there is some evidence that the bile reflux is significantly lesser after a retrosternal. Maybe there is a slight kink at the pyloric end, which is preventing the bile from coming up. But whatever is the reason, there is a significantly less bile reflux. So I think that's a very important point to consider when you want your patient to have a very long life after that. But I don't think whatever literature is available in children, there is not much difference between retrosternal and transhiatal or posterior mediastinal route. That's what I can say. But retrosternal, the dissection is much simpler.
Minutes to counteract each other. So 2 minutes for you and whatever extra point you mentioned.
I think most of the points have come out, but you will have to accept posterior mediastinal route. There is no question about it, because it is obvious, nature has given it. You have to obey the nature, because we don't have any other option, whatever we try to construct. A lot of spatial complications or disadvantages you were trying to project about posterior mediastinal route, but those complications and all are not really very common. Say, for example, recurrent laryngeal nerve. I would say recurrent laryngeal nerve injury perhaps can occur in the neck. So it will not be very different for you also if you are doing a neck dissection improperly. So there is no question about recurrent laryngeal nerve, which is taking away this case from you. And most of the time it is neuropraxia, and it recovers within few weeks to few months. So that is another important point which I thought, which I have not brought. As I said, one has to be familiar with another technique. Yes, I do agree. If I find some situation, because in 136 cases, if I can do in 134 cases, yes, well, but those 2 cases I had to do a retrosternal approach, and yes, I must be familiar with that. But getting familiarity with substernal route will be a bit easier. But if you are not familiar at all with the posterior mediastinal route, you cannot think of.
Okay.
That is all.
Okay.
No, I never had the need to do a posterior mediastinal approach. So I have always done it, retrosternal, and I never felt the need to do the other way.
Okay, as there is already warning bell has rang on me that you have to close the session early. So because there is oration time is fixed. Anyway, lot of questions are there. I am sorry, I cannot permit because organizer is behind me and they are telling that you have to curtail down. So anyway, both of them presented nicely, but I have only 2-3 questions or points to be raised. One is how many incidents of pneumothorax you are having in cases of posterior mediastinal route, and what is the precaution you are taking, number 1. Number 2 is how to prevent postoperative esophageal gastric anastomotic leak or stricture. What is your technical innovation for that? And number 3, lots of people are saying that both are equally good, but obviously normal pathway is preferred than the abnormal pathway. So I strongly believe the normal pathway should be preserved, but for the beginners, it should be retrosternal route to be tried first, so that they are experienced enough to venture the mediastinum. Otherwise, you will have landed into lots of dreadful complications, which is comparatively less to learn and at the beginning learning up. So this way, I would like to conclude that session because already they have told that you have to cut it down. Anyway, but I would like to thank both the speaker for the excellent presentation. And I though everybody knows who is the winner, but I personally, as a referee, make them joint winner. Thank you very much.